Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to this episode of the Gastro Girl podcast. This episode is brought to you with support from Ardelyx. We are so excited to have the amazing Dr. Gut Motility on the show today, otherwise known as Dr. Kumkum Patel. She's a board-certified gastroenterologist and an IBS and motility specialist in Southern California. And please don't forget to like, subscribe, share the Gastro Girl podcast with your friends and family, and rate, review on all your favorite platforms, including Apple and Spotify. That would really help us out in getting this episode and our rest of our podcast episodes out to more people who are in search of this evidence-based information. Welcome, Dr. Patel. So happy to have you on.
Thank you so much. It's such a pleasure. I love your podcast and I'm so pumped to be on it. Thank you so much for having me.
Well, I love what you do. And for those of you who are listening, at Dr. Gut _motility, her platform, she does amazing things on Instagram. I'm not really on TikTok. Are you on TikTok?
No, well, I am, but I'm not really. Like, I go on there times when I remember to post things, and then I'm like, okay, cool. 5 people saw it. Awesome. Great.
But your content is mostly on Instagram, and it's fabulous. Like, there's so many great tips and insights.
Thank you.
I have no idea where you have all the time to do all this stuff, but it is amazing. Just for those listeners who may have found this podcast without watching some of the more introductory episodes we've had, what is IBS-C, or otherwise known as Irritable Bowel Syndrome with Constipation, and how does it differ from other forms of IBS?
Yeah, so Irritable Bowel Syndrome with Constipation is defined by the Rome Foundation. They look at people having abdominal pain recurrent, happening at least once a week for the past 3 months, along with changes in what their poop looks like, the character, and the frequency. So obviously, when you think of constipation, it's happening infrequently. And so not only is it happening infrequently, but other symptoms are also accompanying the IBS, which is what makes it IBS type C, which means that they are doing things like straining for at least a quarter of the times that they're pooping. It's hard or lumpy at least a quarter of the times that they're having bowel movements. And it's fewer than 3 spontaneous bowel movements. So that means that without having taken laxatives, it's less than 3 times per week. So it's abdominal pain with the constipation for at least the last 3 months with those other combination things combined.
Oh, wow. And how is it diagnosed? You mentioned the Rome criteria. So if I go to my doctor and I say, I just have been having trouble going and I think something's wrong, like how is it diagnosed?
So ideally, with a good history, a good physical exam, it can be diagnosed without having to do a large amount of testing like colonoscopies and other, testing, which we'll talk about in a little bit. But history and physical is first, but we also have to make sure that there is no obstruction or issues with the pelvic floor or any other thing that's contributing to that. So if all of that is kind of ruled out with a good history and physical, then we could likely presume that it's most likely IBS type C.
And how is it diagnosed? It's just, is there any do we have to go under an x-ray or a scan or is there a blood test?
Yes. What? So the first things first, your doctor should be asking you, how long have you had these symptoms? And tell me more about them. When you are pooping, are you pooping a few times a week? And when you are sitting down, is it that you are having to strain when you're having these bowel movements? When they ask you a history of your medication. So they'll do a thorough workup. Have you had any sexual trauma? Have you been taking new medications like Ozempic, the new GLP medications, which are supposed to slow down how the poop moves through your system? Have you been taking new calcium containing medications? Have you had any other pelvic floor surgeries? Has there been rectal surgeries? Did you have a baby recently? Did you have trauma in the past? Those are all things that can be contributing to either pelvic floor dysfunction or IBS type C. So understanding that is first. Second, you'll get a digital rectal exam to make sure that there isn't an actual blockage where the poop should be coming out. Because if you've got a blockage in the outlet where the poop is supposed to come out, that's a problem, right? Whether it's an actual blockage from, let's say, a tumor, for which, you'll need a colonoscopy, which we'll take a look at the entire lining of the colon. That'll help rule out obstructions or blockage. or if there's an actual blockage in the sense that your muscles are not allowing that poop to come out. So both of those can be causing an obstruction. And then once those are ruled out, they can do some other further testing to see if it's just IBS-C or IBS-C with an overlap of other types of constipation.
I'm glad. I just want to stop for a moment because you mentioned the rectal exam, digital rectal exam. And I've been a huge fan of Dr. Jossman for years and read, lots of his reports and seen him. And he's one of the proponents of that this isn't done enough. And some patients we've heard never get asked or get examined in that way. And, what did you, before we go on, for patients that are listening and maybe they're having an appointment and the doctor doesn't do that, how do we ask for that without feeling embarrassed?
Yeah, you should say, I would really appreciate if you wouldn't mind examining to see if there's anything else that could be contributing to my constipation. Not so that you say it in an accusatory fashion, because any doctor could feel on the defensive, like, oh, hey, how come you're questioning why I am doing, why are you questioning my way of treating? But, that it's very important for you to ask and say, hey, would you mind taking a look to see if there's anything else that could be contributing to my constipation?
For those of us who may be a little trepidatious about the digital exam, could you tell us what that would entail?
Yeah. So, your doctor ideally should ask you to dress from the waist down and to lie down when doing this digital rectal exam. Ideally on your side. This actually exposes your bottom and allows for your doctor to see what is actually happening on the outside of the rectum. Do you have hemorrhoids? Do you have a tear called a fissure? Do you clench your bottom muscles to prevent your doctor from doing that pelvic exam? Because that can actually signal that you may have a hypertonic pelvic floor or a high rectal tone. When your doctor actually does this exam, obviously they're going to be wearing gloves. Make sure that they do, and they should use some type of lubricant gel, and also tell you, okay, I'm going to insert my finger now, so you're not completely clenched up, and you're expecting the digital finger or the phallus to go in there. And so, okay, here's the digital finger. It's going in. And then, your doctor should feel on the inside to see if there are hemorrhoids. They should feel if there are tears or fissures. They should also see if there's anything protruding on the outside. They should also ask you to bear down, and they're going to see if they feel something called a perineal descent, which means that they feel the pelvic floor coming down, which is what happens when you're pushing poop out, okay? One arm of the doctor should also be on your abdomen, because it's your abdominal muscles that are the important part of generating the strength and pressure to push poop out. So if you're not using your core and your abdominal muscles, that could also be part of the problem. So they should see and confirm that you are using your abdominal core muscles to push poop out while your pelvis is descending and while you're attempting to keep it in there. So all of that is part of the digital rectal exam.
That's really helpful. And I don't think we've ever had someone, really explain it to our listeners. So we really appreciate that. It's so important. It's so important, especially, as we learn more and more about the role of the pelvic floor that often gets missed. And the more we can educate patients about that role, it's so key. So once we're diagnosed with IBS-C, what happens next? Like, do you tell me I have to do a different diet? Is it a multifactorial approach, multidisciplinary? Like, what happens next?
So the important thing, at least when you're in my clinic, the important thing to realize is that IBS oftentimes overlaps with other types of constipation. So it's usually not alone in its presentation. Over 2/3 of patients who have IBS usually have underlying pelvic floor dysfunction, which means that their pelvic muscles are not coordinating probably because they've been constipated for so long that their pelvic rectal muscles have learned and taught themselves how to squeeze or to act, right? You hear about people being like, okay, well, every 3 days I am really constipated, but it's time for me to go. And I sit on my toilet and I do a dance routine and I go from side to side and I push on my belly and then I have poop come out. And it's only the days that I take my Miralax and my prune juice that I'm having that, right? And so understanding what it is that they have, if they just have IBS-C, they might receive a medication to help with that. There are multiple classes of medications, such as linaclotide, lubiprostone, plicanotide, prucalopride. These are medications that are activating different channels in the actual lining of the intestines, allowing for water to be pushed in, allowing for the nerves in the intestines to be calmed down, and allowing for the muscles of the actual colon to be told to actually move so that poop can actually move along, right? So that's what would be the medication portion of the IBS. Sometimes these are not enough, right? And so talk to your doctor if there's a stress or an anxiety component that is triggering your IBS type C, right? And for that, a lot of patients really benefit from getting a medication like a neuromodulator, something that's going to calm down the nerves in the GI tract as well as the brain. And examples of that can include sertraline, which is Zoloft, or nortriptyline, which is Pamelor.
That's I like how you bring in the mind and the gut connection, because that's so important. And, just because you're a doctor, just because your doctor tells you should be on this neuromodulator doesn't mean you're crazy, doesn't mean he thinks it's all in your head. Talk a little bit about that connection and why that type of SSRI would be prescribed to a patient with IBS and IBS-C.
Yeah, absolutely. So a lot of IBS is because there's a disorder of gut-brain interaction, right? That's how it's defined. It's not just that it's a functional disorder, it's a disorder of gut-brain interaction, which means that some component of stressor from the brain has then transmitted a signal to the nerves in your gut, which is considered the second brain, right? Your enteric nervous system is called the second brain. And that has received a message of some type of underlying distressor, whether that distressor is a physical distressor, a psychological distressor, a dreamlike distressor of trauma from the past. Any of those can cause something called visceral hypersensitivity or nerve hypersensitivity. That tells the body that it should stay in a state of like fight or flight. It should be in like a low dose mode of fight or flight. So think about it. If you're fighting or flighting or running away from like a tiger in the woods, right? Pooping is not on the forefront, right? If you're trying to run away from that tiger, you got to get out. You got to get out of that forest before the tiger gets you. So you can't stop to poop. You can't stop to eat. So guess what your bowels are supposed to do? They're supposed to hold on and freeze, pause until you're safe, until you're relaxed enough to go pee, poop, do all the rest and digest functions. So in a lot of people who are stressed, their bodies go into a low dose version of the fight or flight. And their bodies are like, oh my gosh, I'm not in a place where I'm, relaxed. Until my body is relaxed, I'm not going to poop. So they stay that way until maybe they get to their home bathroom or they are done with whatever stressful event it is. And then they can have a nice bowel movement.
Just so patient, we have like kind of a structure, understanding of what types of FDA are, there's obviously the over-counter treatments, but we're talking about when those are failing and they come to the doctor and now they're potentially ready for a prescription. What are the current options and how do they work? And there's some newer ones that have come up on the market as well. And how are they different? And how does the patient know which one they should be on?
Absolutely. So, there are great medications called GCC agonists, okay? And examples of these are called linaclotide, or the proper name for it is Linzess, or plicanotide called Trulance. And the way it works is that it increases the amount of fluid that gets secreted into the actual bowel and also moves along the motility of the muscles in the colon itself. It also helps by blunting the hypersensitive nerves that are in the colon. And it activates the guanylate cyclase C on the intestines and moves it through so that the poop can move along. Okay, that's one type. Another type is lubiprostone or Amitiza. And again, this also helps increase more fluid into the bowel, so you get this softer poop. It activates chloride channels in the lining, increases fluid to be secreted into the lining, and makes it easier to have a slip and slide for the poop to come out. Okay, so that's two different types. A third type is prucalopride or motegrity. And again, this is a 5-HT4, so serotonin receptor agonist. And this stimulates the serotonin receptors in the gut to kind of move along. it again allows for peristalsis to happen. Okay. So those are different types. And the most recent one is called tenapanor or Ibsrela, which uses this, the sodium channel blockers, inhibitors to kind of get more fluid and to push the poop along.
So, wow, there's on one hand, it's great news for patients that there's so many options available. But on the other hand, it's confusing. How do we know as a patient which one we should have? Because they do have different mechanism of action. You mentioned the sodium for the last one, and the other ones worked by drawing water into the intestine. Could you explain like how we would know which one with our doctor? Like, how do you make that decision?
So, if you should tell your doctor if your IBS type C has more pain or just has more of the constipation, because medications like linaclotide and plicanotide help with people who just have the constipation, and are their most bothersome symptoms are the bloating and the constipation. Okay. If your symptoms have not only the constipation, but also have the abdominal pain and the bloating involved, then a medication like Ibsrela or tenapanor might be a better option for you. And sometimes it really isn't dependent on what you and your doctor find best in terms of what works best. It might be that you may have to fail a trial of Miralax, of Senna, of Linzess until your insurance says, okay, fine, you can have the plicanotide, you can have the Trulance now. You've failed everything else and you've tried everything under the sun. Fine, you can have the really good medication. Or, you kind of have to prove those things to the insurance company before that gets released to you.
Wow. So in terms of failing all these things, what are other ways? And I know it's not a one size fits all, but generally when you're speaking to your patients, when they find out they have a chronic condition like IBS-C, in terms of management and overall lifestyle, what's the role of diet and nutrition, exercise, stress reduction? And are there anything else that you would, educate your patients about?
Absolutely. I mean, diet is a huge part of IBS type C. I mean, half of the reason we get IBS is also because there's a thought that there is what we call dysbiosis or change in the bacteria or microbiome. So feeding our microbiome or that gut bacteria with good foods that include fiber in them, at least 25 to 38 grams of fiber a day. So just call it 30 for the sake of numbers, at least 30 grams of fiber a day. That's going to help feed that bacteria, that probiotic bacteria in your gut to kind of start moving things along, making those happy hormones like serotonin, which keeps your bowels happy, which keeps IBS lower, right? That's number one. Number two, moving your body will move your bowels, right? Some study shows that as little as like 10 to 12 minutes of walking a day can help your bowels move along. So it doesn't have to be all 10,000 steps that you're supposed to get. Okay. Sometimes I look at my Apple Watch and I'm like, cool. So I've done 4 colonoscopies and I've walked 10 steps in between each room and back to the endoscopy suite. And I'm like, 10,000, like that's not going to happen today. Right. And so if you could at least go for a small walk, 10 minutes, 12 minutes, 15 minutes, and you make it a good walk where you get it through nature, that should help release some endorphins and gets the motility of your gut going.
I think that's such a great point. Like what you said, you don't have to, walk 20 miles. And I think this is, I do this. I used to be a big marathon runner. And when I was tapering down, I would feel guilty if I wasn't running 10 miles a day. And so I wouldn't go on a run because, I'm not going to run. And it's okay to run. You don't have to run 10 miles a day. You can run 2 or 3 miles, 5 miles a couple times a week and do other things. I think we put so much pressure on ourselves to do the big thing that we forget the small things.
Correct. If you didn't get all 30 grams of fiber, it's okay. Did you get at least 10? 10 is better than 0, right? You didn't get all 10,000 steps, but did you at least get 3,000, 4,000? Great, right? Aim for something, right? And the more resistance training you can do, as we're learning that muscles really are the center of longevity, of overall life and overall health, that, we can do better for ourselves. The more resistance training you can do, the more you can get your muscles to help produce those short chain fatty acids. That's the things that the gut bacteria produce to help keep the lining of the gut healthy. Exercise does the same thing. So go out there and move your body, right? That walking is going to help generate that short chain fatty acid. That weighted exercise that is going to help with your insulin resistance. An easy way, I think, is the weighted vest. And I recently invested into this. Getting a weighted vest, which is like you can get it on Amazon. It has to be at least 10 to 15% of your body weight. Okay. Getting this and wearing it while going walking helps with getting
Cardio.
your heart rate into the zone 2 cardio training, which is great for fat loss. It also helps increase your heart rate so that you're maximizing the productivity of that walking. It also helps with generating good muscle mass, prevents osteoporosis, gets it all done all at once. So if you're like, oh my God, I don't want to do weightlifting and walking, like I can't. Okay, well, put on a backpack or put on a weighted vest. You can get it on Amazon. I got mine for $19.99.
I love
And
it.
yeah, and you could just get one. They come in cute colors. Get a 10 to 15% of your body weight. You can always start something small, start like 10 pounds and move up. Go for a walk. And after you take off that vest, you can be like, okay, 10 minutes and I feel a lot better.
Well, and there's also recent studies that we've seen that just being in nature
Yes.
can help with our mood and subsequently our symptoms of IBS.
Yes.
And I love those studies because it's so practical and we can all relate to that.
Yes, getting sunshine to hit your eyes will actually get your melanocytes to release serotonin, which is the happy hormone we were trying to get our gut to produce anyways, right? So get your brain to see some sun so you can get that same serotonin because your gut will thank you and move things along.
And I know we're going to get this question, so I'm going to ask you, what do you tell your patients when they ask you, how do I get my fiber? What's the best way to get my fiber?
So
what are some options?
Lazy man's trick is 30 grams of chia a day. So that's 1 tablespoon has 10 grams. So 3 tablespoons of chia a day keeps the GI doctor away. Okay. So that's my say. Okay. 3 tablespoons of chia a day will keep your GI doctor away. Why? Because 3 tablespoons of chia seeds has a total of 30 grams of fiber. So even if you're not a super kale salad eater or broccoli lover, I get it. It's not easy to incorporate it. Then it's hard, right? You're trying to get your macronutrients in. You're trying to get your calories down. You're trying to do all these things, and you have to get your fiber in. So yeah, a tablespoon of chia seeds can be thrown into water. It can be thrown into your protein shake. It can be tossed on top of your eggs, your salad, and that's 10 grams. So if you do it breakfast, lunch, and dinner, you've hit your goal.
That's fantastic. Any other options if people aren't into that?
If they aren't into chia seeds, obviously they could do, kale smoothies. They could, get them from actual veggies. And then you can do the fibers. There are so many fiber supplements. There's sun fiber, there's psyllium husk. Now, there's all these tasty ones that are out there.
With the gummies, do you recommend the gummies? But watch the sugar. You got to watch the sugar though.
Even the sugar-free gummies, the problem with that is they only have 2 to 3 grams of fiber per gummy. Right. So you're going to have to eat 10 gummies in order to get like 1 day's worth. And like the bottle only has like 28, right? My kids, I give them, I tell them that's their treat is the gummies. And so, if you're going to get the gummies, you have to eat the whole damn bottle just for 1 day's worth. So I don't know if a gummy is sufficient, but it's a nice treat. Like if you're going to do a treat, fine, do a fiber gummy treat.
Well, that's wild. Yeah. I mean, because they sell them, they're all the rage. I'm like, oh my God, I have to eat like half the bottle.
Yeah, literally. And then you're like, wait, that's only 2 days worth. That's a really expensive gummy.
Oh my God. So in summary, what are your top tips for managing IBS overall? And especially for, having those conversations, which can be difficult for some patients because some of us may be afraid to not challenge, but question if this is the right treatment for me.
So, the big thing is making sure that you and your provider discuss not only what your symptoms are, but what your history includes. Because if your IBS type C is overlapped with pelvic floor dysfunction, if it's overlapped with sexual trauma, if it's overlapped with certain medications, you need to be upfront about it because your treatment is tailored to what you've actually got. So if you have severe anxiety and depression, and that is affecting your constipation, just getting on a Trulance or Linzess may not be enough. You may also need, a sertraline or Zoloft. Or if you had sexual trauma in the past and you've got bad IBS-C, but your pelvic floor muscles don't want to open up and relax and allow for the poop to come out, doesn't matter how much medication we give, you're going to want to not allow those muscles to relax. So getting into a pelvic floor physical therapist or getting a manometry study, which tests those muscles so we can understand which actual muscles in your pelvic floor are miscoordinating. That is important to do. Okay. So ask your doctor what else could be overlapping and let them know all your symptoms and your history.
And I think that's so important when you're talking about if you're not getting any results from the treatments. And I'm going to say this, I say this in every podcast I do, is the abuse of laxatives. I've seen this in my own family with my grandmother. She didn't have a good day unless she had gone to the bathroom. And I remember as a kid seeing all these different types of laxatives and, Nani, like, oh, what's wrong, Nani? You don't. But in all seriousness, we want to just emphasize like why it's not a good idea to continue to be on this laxative train.
Correct. And there may be an underlying issue. I will never forget, I had a patient who had a lot of IBS type C symptoms, but he ended up having stage 4 cancer. And I had to, again, if you come to my clinic, you are going to get a colonoscopy, because after I saw this 39-year-old patient who came in for constipation was his only complaint, and he had a stage 4 cancer that was actually causing an obstruction. And he was having, pencil thin stools, which I was like, oh yeah, that's your IBS because you've got so much stress going on in your life. And he told me, they're about to have a baby. They moved to a new house. They had all these things happening, all these stressful events. And I did a colonoscopy, and lo and behold, it was an apple core lesion, which means it's like basically blocking the whole colon. There's a very small, thin area that's open. And I was like, God, like younger and younger people are being diagnosed with colon cancer. So it's not off the table. So when people are like, oh, do we have to do a colonoscopy? If it's been a long time that you've had this constipation and it's not getting better, it's better to be on the safe side and get that colonoscopy to rule out that obstruction, because God forbid you're that person who's got that tumor. Both you and your doctor will be so sorry that you didn't do that colonoscopy earlier.
And other things too. Chronic constipation can be present in other conditions, especially for women. And can you just, I know, just because I think this is such an important point that you're making, I just want to touch on it. What are some of the overlapping diseases that could have this as a symptom?
Yeah, so chronic constipation, obviously, it can happen in celiac disease. It can happen in inflammatory bowel disease. It can happen in pelvic floor dysfunction. It can happen in people who have been on medications for diabetes, right? A lot of diabetics, their intestinal emptying is very slow, right? So they're just, told that they have gastroparesis, and, they go on these diabetes medications, these new GLP-1s, which are great for diabetes, but guess what? It slows down the emptying of the intestines. So that's going to worsen their underlying constipation, or they have thyroid disorders, right? Like they have been struggling with weight gain. They've been on thyroid medications and it hasn't been addressed. Hypothyroidism can slow down your bowels. So if that's not properly addressed, all these other comorbid conditions can certainly cause you to have chronic constipation, and that needs to be taken care of as well.
No, thank you for that reminder. It's so important that we're all aware of that. Did we miss anything, or any final words you'd like to tell our listeners today?
I think that it's important for people to realize that constipation is not just slow bowels, and that there is, ways that you can not only do medications, but, exercise. There's now cognitive behavioral therapy, which is a way that you can kind of retrain your brain to understand your triggers and foods that kind of help or are hurting your symptoms. There's a new app. There's actually a few new apps. There's one called Nerva, which does gut-directed hypnotherapy. There's one that's called Mahara that does cognitive behavioral therapy that's actually FDA approved for IBS. And so both of these are really great because it actually, is tailoring to the brain portion of the gut-brain connection, right? We can't talk about IBS-C being a disorder of gut-brain interaction and just treat the gut. We have to treat the brain as well.
Yeah, I'm so glad you brought up the apps, because there are some really successful and evidence-based apps out there. And we've learned so much about the brain gut access, which has really made a huge impact on the way patients are being treated. So thank you
Yes.
for that.
Absolutely. And patients, if you don't have a provider who knows or is knowledgeable about any of these things, I've actually opened my practice now nationwide for telehealth for second opinion consultations. If you don't happen to live in the state of California, that's okay. You can visit my website, kumkumpatelmd.com, and you can click on educational visits. And you can make an appointment to see me via telehealth. And we can go over a plan that you can discuss with your gastroenterologist. Like, okay, you need a XYZ medication, you need a defecography, or you need to be checked for a rectocele, you need to be checked for pelvic floor dysfunction. And we can talk about what medications or treatments may be helpful so that you can take it back to your doctor so they have a roadmap for what may be successful for you.
I love that. I think that's so smart. As an entrepreneur, as a business woman, I think that's brilliant, because one of the problems that patients have is getting access to the support and guidance that they need. And that's huge. I mean, to be able to have like a roadmap that you can go to your doctor, because how much time do we really have with our physicians these days? Not much.
Correct. I give a whole hour, or you can choose between a 30-minute consultation or a 60-minute consultation, but you have a whole hour where you can send me all the things that you previously had done so I can review it. And then we can figure out a game plan that you can talk to your doctor about that works for you. And then we can discuss, if it's not working for you, what else we can change, right? Not everyone has access to, motility or IBS trained physicians, and that's okay, right? Now there are doctors who are available, and telehealth has made things wonderful in terms of access. And I want to be, accessible for you and the listeners. So if you are here, if you're listening to this, if you don't have a provider who can help, please feel free to reach out to me and make the appointment.
That's fantastic. And also, it's like you pay money to have SAT preps or those kind of preps. It's like, why not prep for your doctor's appointment with someone that's really knowledgeable? And do you work with primary care? Like, say someone doesn't have gastroenterologists in a rural area, you could kind of give them the roadmap and they could prescribe whatever.
Absolutely.
I love
Absolutely. An entire write-up, and that write-up goes back to the patient and they can take it, and it's line by line, what medications, what testing, what treatment possibilities, what differential diagnosis possibilities are happening. And so all of those go into the assessment, and you get this one-page sheet that you take back to your physician and you can tell them.
Well, we're going to put up the information so people can find you online and find your website. Thank you so much, Dr. Patel. This is fantastic. I hope we can do this again. This is great. Thank you so much. And we'll have all the links and information in the description. Thank you.
Thank you so much. This has been an absolute pleasure, and I look forward to doing it again.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.